A warm welcome from Amsterdam to all of you participants and viewers. This is day 2 of the Alzheimer Europe conference, Dementia in a Changing World, edition 30 already. So you're well known with the conference, I feel, and some of you might be here for the first time or for the first day, and the other ones were here yesterday as well. We are curious to find out if your executive director, Jean-Georges, is here to welcome you, because hi, there you are, Jean.
Good to see you again this morning.
Yeah, it is. It is very, very grey in Amsterdam. How's the weather in Luxembourg City?
Unfortunately, if I'm looking out of this window, it's not any better. So it's much better sitting here in front of the television or in front of our computer screens and watching the Alzheimer Europe conference and being.
Yes, it's the best. It's the best thing to do, right? Just stay in and stay with us. That's a good idea. But maybe in the other countries, it's lovely weather. We don't know. Maybe we'll find out later. Yeah. So, did you sleep well?
I did indeed. I slept much better yesterday than the night before because I thought yesterday we had a great day and a great start to the conference. So
did, yes.
Confident.
I just thought it's raining cats and dogs, and it reminded me of yesterday, right, Jean? Maybe you can tell us a little.
We had a great on Twitter, so a lot of people have been tweeting about our conference. They've been using the hashtag 30AEC, and as you can see from there, there's a number of people that also were really inspired by Helen's message.
Yeah, can we see that slide back?
Really important about her normal life and how her dog really made a difference to her social isolation. So a number of people used the hashtag cats of 30AEC or dogs of 30AEC to really show how they are interacting. We've also got an image of a chicken, so I'm not sure whether people always understood cats and dogs. But
chicken of 30AEC is lovely as well, but 30AEC is the normal hashtag, so people were asked to send in animal pictures. Very, very special. But we also have very serious matters to discuss, right, Jean? Although dogs are quite serious to many people, they are.
Absolutely, but today we have another action and information-packed day. We are starting this morning with diagnosis and medical management of dementia. And this afternoon, we're talking about dementia-friendly communities and dementia-friendly society.
Yeah.
And we have, as I mentioned yesterday, we have absolutely world-leading experts that are here today. So it should be a very interesting morning session.
So yes, that's true. And we also would like to connect to you, of course. We want some interaction here. And for that, we have the app. You see it in your screen, on your platform. And there were questions already here. But somebody said, and many people voted for that, great music again. So we're happy that they feel that way. But we want to start with asking you a question, because, of course, we're curious if you are here for the first time or did you come back? People who say create music again were here yesterday as well. That's probably the case. But so if you want to please answer our first question, is this your first or second day attending this year's conference? And then the choice is easy, first or second. I think people can manage that, right, Jean? Let's see what they do.
I would imagine that we're starting with an easy question here.
Yeah. Yeah, maybe if you do remember what you did yesterday. Yes, okay, so maybe we can say, oh wow, that's good. People are very loyal to the conference because they were here yesterday as well, as I see it now. And welcome to the 12% first day viewers, because we're really happy that you are here. And of course, it's 3 days, so you have the opportunity to come in whenever you want. You see it, Jean?
Yeah, it's good to see that people are loyal and that people are coming back as well.
Yes. Yeah, we didn't scare them. We didn't chase them away. That's a good thing. So we want to ask them another question, and this regards the people that were here yesterday. Of course, we will ask you the same question maybe tomorrow for the people who are joining today. But we want to know, well, what did you learn or experience? Can you maybe open that poll for me, Jean?
That poll is now open as well.
Yeah, is it? Good. Yes, describe in a word, which is always a difficult matter, but please try. Describe in a word what you've learned or experienced. Wow, people are entering rapidly. Technology, they learned. That's interesting. It's a big word. Thing, they learned thing. How can you explain this, Jean? Thing.
That's I think that's even beyond my understanding. I can much more easily talk to why people would choose care, inspiring, but thing is not necessarily
No,
the
but
easiest thing to explain.
like today, we have many sessions and workshops and speeches and posters, so maybe there was something there with a thing. I would like to see that results a little more because it's too fast for people to take a look at. Yes, let's keep it there for a while. COVID-19, yes, we were talking about that. They learned fear, Jean, or maybe they learned a little about fear and about they had knowledge. That's good. Assistive. What do you think that means?
It's also because we had a lot of sessions around assistive technologies and how, especially during COVID-19 pandemic, assistive technology were used to either help in nursing homes, in people's individual lives, also even in the recruitment for clinical trials. Assistive technology really has become something that is much more part of our world than it was before.
Yeah, and it's good. It's a good thing that there is more that assists, right?
Absolutely.
Okay, so now let's move on to our next theme. This is what I would suggest. An important theme, and we have 4 speakers. They are ready to tell you about their experience and their research and everything they know. And we will keep talking to you through the app, the IO app in your screen, and we will ask you questions all the time, but you please feel free to give your comments, ask your questions all the time, because we will read them and we will try to use them or mention them. But the first theme of the day, diagnosis and medical management, why do we talk about that, Jean?
Well, it's definitely an area where we are lagging behind a number of other diseases where diagnosis is still very often made late. We have great percentages of people that are unfortunately not diagnosed at all. And so we definitely want to hear from our speakers today on how we can improve the diagnosis rates. We also want to hear maybe and get some hope around how close we are to getting new treatments. We also want to get an understanding of some of the ethical issues that are raised by the kind of changed definition of Alzheimer's disease. And then last but not least, there's a whole range of non-treatment issues that are important in the medical management of people with Alzheimer's disease. And we'll also hear about some of those aspects.
Yes, a lot to talk about. So we will have presenters. They will speak for about 15 minutes. And after that, we will ask you a question about the theme. And after the 4 speakers, we will come back with all of them together. And then we will ask them your questions. So please send in your questions. And maybe you can add the name of the speaker with it, so we know who you want to ask the question. Let's start. Maybe, Jean, you can introduce our first speaker.
So first speaker is Pierre KROLAK-SALMON. He is a neurologist and geriatrician at the University Hospital of Lyon. He's also the president of the French Federation of Memory Clinics, but his CV is a bit too long to expand on here. But the main reason why we have invited him here today is that he coordinated the work of the Joint Action on Dementia, which was financed by the European Health Programme. And he looked there where he coordinated all the work package on timely diagnosis and post-diagnostic support. And what he's presenting here today are the kind of key recommendations of that joint action. So over to you, Pierre. We're delighted to have you here.
Hi, everybody. It's a great pleasure for me to be with you today, even if we are far from each other, but we are close by heart and by brain also. Yes, I think you can see my screen. So I would like to thank warmly Alzheimer Europe for inviting me to present the proposition of the second European Joint Action on Dementia regarding the improvement of diagnosis, the quality of the diagnosis, and also the rates of the diagnosis in Europe. So it's a collective work from the French team with Armelle Lepère-Desplanques, Leslie Katz-Piver, and Bertrand Fougère, and also the involvement of Italian teams, of Bulgaria, of Norway, of Poland, of Greece, and also the great involvement of Alzheimer Europe. So, as you know, we are facing a misdiagnosis, an underdiagnosis in Europe, as Jean reminded us just at the moment. And you may know that the first joint action dedicated to dementia proposed the concept of timely diagnosis that is really relevant, occurring right earlier than the current late stage diagnosis in Europe. And after neuropathological changes, after the occurrence of biomarkers, positivity, and this timely diagnosis is really personalized and depends on the wills of the patients and the caregiver and the needs also of the patients and the caregiver. But we are facing this underdiagnosis. The diagnosis rates reach only 50 or 60%, depending on the European countries. The breaks are multiple. We are facing breaks in general population, but we are facing huge breaks regarding the diagnosis in primary care, and the GPs are facing difficulties. And thanks to surveys and questionnaires, we collected some information from the European GPs, and they recalled that they do not understand sufficiently the diagnosis benefits, and as compared to the risk of the stigma dedicated to regarding the diagnosis. So we have to share clearly the benefits associated to the diagnosis of dementia. They do not have sufficient time to detect neurocognitive disorders in primary care, and they do not fully understand the diagnosis strategy. They do not understand when we propose a neuropsychological inventory, when we propose some biomarkers, not to all patients, and they do not understand what belongs to routine diagnosis and what belongs to research. So we focused on that, and we proposed 3 implementation programs regarding dedicated training to the GPs fighting against stigma. So it's an innovating training dedicated to the GPs, and we'd also try to implement some cooperation between nurse and GP to help them to better detect neurocognitive disorders. And we also explored the role of telemedicine, especially in nursing home, to detect more cognitive disorders. And we worked also on a personalized, graduated diagnosis strategy, on a consensus that we could propose to the community. First, this innovating anti-stigma training that we propose and we tested in different countries. You know the structure of a classical academy training for the physician. It's built on the presentation of epidemiology of the diseases, the neuropathology, the classification, the symptoms, the biomarkers, and the therapeutics. So that's the classical frame of trainings. But here we propose an anti-stigma training to the GPs, and we wanted to focus on the real concerns of the GPs. We wanted first to share the benefits the clear benefits from literature of the diagnosis. The first joint action proposed a list of benefits that was shared with ethicians, sociologists, philosophers, physicians, psychologists, and so on. From the right to know, the time to adjust plan as soon as we get a diagnosis, the ability to make decisions, the improvement of quality of life as soon as we get a diagnosis and a care pathway, the access of innovation on research, clinical trials, the explanation to the caregivers, to understand the changes, the cognitive changes, the behavioral changes, and so on. So we shared these benefits associated to the diagnosis. Then we explained the complaint at risk and the situation at risk that should trigger a diagnosis process by the GP. We also shared how to conduct a detection consultation in the primary care. First the detection and then the etiological diagnosis relevant for the specialist. We shared also some consideration of how to announce a diagnosis and how to share the announcement of the diagnosis. Also the management and care, and secondary and tertiary prevention is really important. We tested the impact of this new training program by submitting some questionnaires regarding the stigma and stereotypes associated to Alzheimer's disease, to dementia, and to these people with this kind of disease. So we proposed this questionnaire before the training and after the training. The kind of stereotype that you may know, the first one here is the diagnosis process of neurocognitive disorder is more the responsibility of the specialist than the general practitioner. This is a stereotype that we can test, explore before and after the training. What we observed is a clear improvement of the stereotype consideration by the GP after this anti-stigma training in most of the centers participating to the trial. In Lyon, in Bulgaria, in Poland, and as a whole from the statistics. The GP confidence improved in all these centers regarding the diagnosis procedure, the disclosure, the post-diagnosis supports, the anticipation of risk. And you can see here in details the improvement in each center with a color before and after the training. You can see the improvement of the sense of competence of the GP. That is really important for the GP to be motivated to better detect the neurocognitive disorders. So it's a clear improvement in the field of diagnosis process, management of psychological consequences, adapted treatment and post-diagnosis supports, and anticipation and risk management. So that was a good result from this experiment. The satisfaction of the GPs, of the participants, was great regarding the quality of the exchanges and discussions, the usefulness of the training in all of the centers. The satisfaction was good or very good. Let's look at the general practitioner nurse cooperation. That was a new program that was implemented in different countries, in France, in Greece, in Italy, in Bulgaria, in Norway, and in Poland. This is the frame of the diagnosis pathway that was proposed in France. You can see that it starts obviously from the patients and the carer. It started from the complaint or a situation at risk. We don't need any complaint to trigger the diagnosis process if the nurse or the GP discloses a situation at risk. Sometimes misunderstanding of anticoagulation drug therapy and so on. So first, the GP interviewed the patient and the caregiver. So there was a first evaluation by the GP. He detected a situation at risk or a complaint at risk. Then that triggered the involvement of the nurse. The nurse came to the GP office once a month, and she could see some patient that was who were selected by the GP in advance. So she proposed some cognitive, some functional, behavioral, and psychological testing, and some reviewing of the anamnesis. Then she provided some results to the GP, some recommendation to the GP, who decided. It's important that the GP decides if he or she refers the patient to the memory centers or triggers some brain MRI scanning and blood testing and also psychometry. Then there was a diagnosis provided by the specialist and feedback to the GP, who was at the center of the care pathways. There was some discrepancy, there was some variability regarding the structure of the program of the GP nurse cooperation across the centers in Italy, Bulgaria, France. And there was also an agreement regarding the scales and the testing that we would use regarding autonomy, cognition, and behavior. Not everybody shared the same testing, but we could combine the results, and that was pretty interesting regarding the type of diagnosis hypothesis that the nurses could provide to the GP, and the specialists could confirm the type of diagnosis and confirm the hypothesis or not of the GP and the nurse. There were some care proposition. You can see at the back of the slide the type of care proposition that would be proposed by the consortium of the nurse, the GP, and the specialist. It was a shared care plan proposed to the patient and the caregiver. The motivation to trigger the nurse involvement for the GP was clearly the lack of time, the lack of knowledge of the detection program for the GP. They wanted to test also the device and to participate to research. As you can see, the satisfaction was full for the GPs, the physician, and the families in Bulgaria. It was very high in Bulgaria and Italy, and it was good or excellent in France regarding the overall experience, the usefulness of the partnership, and the quality of the exchanges. So from that experiment, we can say that the GP nurse collaboration to detect in primary care the neurocognitive disorders and to send the patient to the specialist in town or in memory clinics is very useful for a graduated diagnosis strategy. We tested also the telemedicine in nursing homes to try to enhance and to involve the nursing homes in the detection of cognitive disorders. But we faced a lack of motivation of the nursing home, a lack of time of the professional in the nursing home to participate to telemedicine, to better test the patients and detect the neurocognitive disorders. The nursing homes wanted some help in priority to help them for the behavioral disorders diagnosis and care. That was the priority for the nursing home. There was a good experiment in Greece, and there was a teaching program for the professional to better detect the cognitive disorders in Greece, but we failed in France and Bulgaria regarding the detection of cognitive disorders, but not for regarding the help for behavioral disorders. So you can find in the report from the joint action on the website all the recommendation, the main conclusion, the main message, the barriers, the facilitators, the cornerstones, the proposition for each of these topics. And I don't have the time to detail this, but you can find this on the website of the Act on Dementia European Joint Action. And finally, we worked on a diagnosis strategy because the GPs, the primary care professional, do not fully understand the diagnosis strategy. And we wanted to check if we can share, if we can agree on a graduated and personalized diagnosis strategy. I will not have time to detail the steps, but you can see, and it is published in the Journal of Alzheimer Disease, you can see the graduated strategy beginning from the patients and or caregivers complaint or a situation at risk. The first level interview and testing belongs to the primary care, the nurses, the dementia coordinators, the GPs, and sometimes in some countries the specialists. So there is the first evaluation leading sometimes to a psychiatric diagnosis like anxiety or depression that should trigger the specific therapeutic care pathways. Sometimes, luckily, there is nothing, there is no cognitive disorders, but as soon as there is a complaint, we should trigger regular monitoring and some secondary, tertiary, quaternary prevention programs and specific dementia prevention program. And already at this stage, the access to clinical trials. Sometimes there is a detection of major neurocognitive disorders that should trigger some complementary investigation, brain MRI scanning, biology, and the specialist evaluation for a specific Alzheimer or related disease program and some post-diagnosis supports. There is some consideration of differential diagnosis, obviously, and also sometimes the analysis of complex cases that should be helped by a third biomarker or a third step of evaluation involving the biomarkers from CSF, the PET scan, and so on. That belongs to the routine diagnosis pathways regarding the complex diagnosis with very young patients, with focal atrophy, with rapid dementia. We also agreed altogether that we should consider the mild neurocognitive disorder stage of the disease. And this mild cognitive disorder should trigger the diagnosis pathways and the etiological diagnosis pathways. As the patient present with a very mild cognitive disorder, they should benefit from more information regarding the risk to progress to dementia and some information to research regarding research and clinical trials. And they should decide if they want to be only followed by the physician, the nurses, and participate to secondary prevention programs. And also they can access to research and specific biomarkers to specify, to better specify the diagnosis and access to clinical trials and research. So we were very happy to share this consensus graduated and personalized diagnosis strategy. And I can tell you that we adapted this in France, and that helped us very much to speak with the GP community and to implement this diagnosis pathways in France, thanks to specific training programs that are now financed by the authorities and are animated by both the GP community and the specialists. That was a very good engine for us to improve the cooperation between GPs and the specialists in France. So it can be adapted in each European country. So to conclude, we can definitely share the benefits of the diagnosis all together with the general population and the primary care professionals. We can provide some new anti-stigma training programs to the GPs and also to the nurses. We can benefit, and the patient and the caregivers can benefit from a GP-nurse collaboration to better detect these cognitive disorders. And telemedicine, for the moment, is mostly helpful in nursing homes for behavioral disorder diagnosis and also care. And you can share now from the publication this new graduated and personalized diagnosis strategy. I want to thank you all, and I thank all the partners involved in the work package dedicated to diagnosis in the second European Joint Action. Thank you very much.
Thank you so much, Pierre. KROLAK-SALMON, you work at the University Hospital Lyon, right? So
Yes.
so are you in Lyon right now? No, or?
Yes, I'm in Lyon. In Lyon, and there is a storm also.
There is a what?
A
Sorry?
storm.
Oh, there's a storm also. Oh, yes, yes. Okay, we have the same weather here. So people are responding, and we will talk to you later after all the speakers. But first, a few quick questions. People want more information. They really are interested in the GP training to reduce stigma. Can they find information somewhere?
Yes, for the moment, it's on the website from the second joint action. We did not publish the results of the anti-stigma training, but we will publish this the progression of the stereotypes and stigma after the training, and we have all the content of the stereotypes that are best improved by the training program. Yes.
Okay, but not released yet, the results. So where?
It's not published yet.
And when do you expect publication?
During the next few months.
So people just have to stay tuned and make sure that they find out. There's also a question.
But I will be happy to share the content of the program if the people write me. Yes.
They write you. Where can they write you?
I can provide my email, yes, to Jean-Georges and to, yes.
Yes, all right, okay. People will find you. Also about prevention, they're interested, but we will talk to you later. But before you leave us, we want to propose a question to the viewers. And we discussed that with you also. So Jean, maybe you can open the poll and people can answer the question. I think that they already started to do so. Yes? You're here.
And the question was, what are the key barriers to timely diagnosis according to them?
Yes.
And the options they had was lack of awareness of the general public, fear and stigma, lack of training of general practitioners, referral delays and waiting lists for specialists, or the kind of perception that nothing can be done after diagnosis.
Or any other category.
We already have over 100 people that have responded to their question.
Right, and still thinking.
Can already show the results.
The stigma was important. Yeah, it's people are still voting, I suppose. Yeah. Well, Pierre mentioned it many times, the stigma. It really counts. What do you think the stigma is, Jean?
Well, the stigma is still the kind of fear of talking about the disease, not being able to share the diagnosis with families and close ones.
Yes, are there major misunderstandings there about the disease?
I think it's still a disease that, well, I would say personally, I was surprised that fear and stigma is so high because I thought that we had been successful in addressing some of the fear and stigma in the population, but this obviously tells me that I was a bit wrong in that kind of optimistic assessment, that I thought that stigma wasn't as important as a kind of obstacle to early diagnosis.
Maybe
what this slide shows us though as well is that if we wanted to find one easy solution, we want to increase the diagnosis rates. What's the one thing we need to focus on? Unfortunately, we need to address all 5 of these issues. And it's not just a simple solution of, oh, well, we just need to focus on GPs or we just need to focus on public awareness. Yeah. We actually need to focus on all 5 areas to improve the situation.
Yes, I do understand. And it doesn't mean that nothing happened on the stigma part. It's just that it's probably a tough issue to tackle. So can we have Pierre to comment on the results? Maybe if he was with us watching that. What did you think? Did you see the numbers, Pierre?
Yes, rapidly. I saw that it's pretty homogeneous, and all these items are pretty relevant, I think, and the combination of them leads to the breaks of the detection in primary care. What we observed with the GPs and primary care professionals is that if they are not convinced of the benefits of the diagnosis, there's no need to enhance the knowledge of the disease diagnosis, the technique of the diagnosis. First, we have to fight against the stigma in primary care. They have to be convinced of the benefits of the diagnosis that are more important than the stigma and the risk of the diagnosis, because they say that there are risks of the diagnosis regarding the stigma around the patient, the consequences in for insurances, the
Sure.
consequences for the family, for the friends, and the risk of depression. But we have to teach them that the benefits are much higher.
Yes, yes, that's quite clear. Thank you so much. We will talk to you later. Thank you for all your information. And you at home or in the office viewing, thank you for all your input and thank you for voting. And many people are in, right, Jean? Yeah, have a good cup of coffee. All of you, please do so. Jean, many people, of course, are asking us, can I see the slides? Will they be sent to me? Is there a recording? How do I keep all this information? Can you tell me a little about that?
So what we will be doing is all the presentations have been will be recorded, and we will be putting them on the platform afterwards. So if you have missed the session, or for example, there's a number of parallel sessions happening at the same time, you cannot do all at the same time. All of that will be made available after the conference, also on the same platform. You can look at the on-demand material afterwards, and it will be available for until the end of the year. So you'll have plenty of time to look at all the posters, quick orals, presentations.
Very, very nice.
At your own leisure.
Yeah, thank you. That's good. So now you know, and this is for the whole conference. So that question is answered, and our moderator will try and answer questions about viewing problems. I think they're mostly solved now, all of them, or how to have a larger screen because the sheets show little signs, things like that. Just ask us, and we will try and answer the speakers. So let's move on to our next speaker, Edo Richard, Dutch, I think. Yes. Good morning, Edo.
Good morning.
Where are you?
I'm now in Arnhem, near Nijmegen, in the Netherlands.
Yes, probably raining as well, right?
It's bright sun here.
No, really? No, it's a small country. We always have the same weather. So Edo Richard, he's a clinical neurologist, and you combine patient care and dementia research. So that's a great combination. You will be talking about the diagnosis of dementia risk, and with or without the use of biomarkers. A discussion that we will try and have later on also about people wanting to know if they're at risk of dementia or not, which is always an interesting and ethical question. But you do have something to present from all the research and projects that you had about dementia diagnosis. So go ahead, please, 15 minutes, and after that we'll talk to you.
Well, thank you very much, and I'd like to thank the organization for the opportunity to speak about ethical issues and the disclosure of diagnosis. So this is Mrs. Smith. She's worried about her memory. She forgets appointments lately, and sometimes she loses things in the house, but she leads an otherwise active and healthy life. And her husband confirms this. And on cognitive testing in your consultation room, you find clear memory impairment, but no disturbance in other cognitive domains. So what do you tell this woman? Does she need additional tests at this moment? And what would be the consequences of an abnormal test? Well, these are questions that are relevant not only in patient care, but increasingly so in patient-related research. And of course, we all agree that a timely diagnosis is crucial. And this is highly dependent on social context, on personality, and also on culture. And most of you will agree that a diagnosis at the time there's full-blown dementia and crisis occur is too late. But as you know, dementia is preceded by months to years by cognitive impairment, which in itself is preceded by years to decades by underlying brain changes causing the cognitive impairment. So what do you tell somebody with mild cognitive impairment, for instance? There's a pervasive assumption that an early diagnosis is beneficial for planning, for control, or for access to treatment. But the question is there such a thing as a too early diagnosis? Well, first, we have to decide on what we're trying to diagnose. And the question, what is Alzheimer's disease, may seem silly, but the introduction of new research criteria have left many people in confusion. Because AD as a clinical syndrome is slowly being replaced by AD as a biological entity with or without cognitive impairment. And this is operationalized by a new criteria system called the ATN system for amyloid, tau, and neurodegeneration. And this includes new disease concepts, such as preclinical Alzheimer's disease or prodromal Alzheimer's disease. But can we use this kind of concepts in clinical practice? Now, some argue we should separate research criteria from clinical criteria. But in the end, I think this becomes a messy divorce with even more semantic confusion. Well, a potential asset of this ATN system is that additional letters can be added because most people in late life have mixed causes of their dementia. So you could add a V for vascular or an L for Lewy body. But if you think about it a bit longer, in the end, almost everybody above a certain age will then end up having a preclinical brain disease. And the question is, who actually benefits from this? Well, this whole system is based on the amyloid cascade hypothesis. And a cascade is a very strong metaphor because it implies that after every step, there's another step, and the end is always the same. But there is an elephant in the room. There's much uncertainty about several aspects of this cascade, and not all with amyloid will move on to the next step, and not all with amyloid will eventually develop dementia. So imagine we would take a CSF sample of Mrs. Smith of my first slide, and it would show abnormal amyloid. What should we tell her? Or should we not test it at all? Well, this biology-based thinking has led to a true reconceptualization of Alzheimer's disease. And the boundary between health and disease is slowly becoming blurred. If we take a look at two major theories of health and disease, first on the left, there's the biostatistical theory of health by Bors, and it implies that any abnormal functioning of any part of the body consists of a disease. But on the other end of the spectrum, there's the holistic theory of health, which says that if you're in a mental and bodily state that allows you to reach vital goals in life, you are healthy. Now, it's clear that the new research criteria follow a biostatistical theory of health, with measurable biomarkers, with normal values, with a normal distribution, and abnormal values. But in the end, this does not hold, because with increasing age, more and more people have amyloid in their brain, but will never develop dementia. And if so many people have it, it's not a deviation from normal anymore, perhaps. This is a complex issue. Now, this shift, this conceptual shift has led to many consequences because we were used to a clinical diagnosis of Alzheimer's disease based on dysfunctioning in multiple cognitive domains and leading to interference with daily life. But now that we're moving towards a biomarker-based diagnosis of AD, it means that we could use biomarkers as diagnostic tests in people with mild cognitive impairment. But of course, we would have to validate this and perform diagnostic accuracy studies to make sure that what we think we are diagnosing, we actually are diagnosing. But while the game is on, the goalposts are slowly being moved. And if you think about it a bit longer, the line of reasoning becomes circular. And obviously, the diagnostic accuracy studies in such a model would show very high diagnostic accuracy. If we look at the aims and the effects of the reconceptualization, there are several proper aims. First of all, it could enable and support research. Well, I think this is partly met because with this ATN system, you can define very specific research populations. It could also enable early detection, but the question is, detection of what? Of cerebral amyloidosis or of Alzheimer's disease? And finally, it can also enable interventions in specific population with disease modification. But this is the future. We don't have such interventions at this moment, and we don't know when we will have them. If, on the other hand, we look at the effects of the reconceptualization, it results in people having an early stage of a disease versus being at risk of a disease. It can create a state of uncertainty and maybe enhance fear for the future, And it can even elicit a nocebo response. It's known that people who have learned about their adverse biomarkers actually do perform worse on cognitive testing afterwards. And this very much links to the basic principle of medical ethics of non-maleficence. But there are also societal effects. It can create a large number of so-called patients in the waiting. And imagine that all these people, some of whom who will never develop dementia, would be treated with preventive treatments. It may have major financial consequences. And this links then to the basic medical ethical principle of justice, because we have to think about the distribution of resources across healthcare in general. We did a systematic literature review on the use of biomarkers in people with no or mild cognitive impairment, and we looked at the arguments brought forward. And in favor, the arguments are that it may be beneficial for research, that it may increase diagnostic certainty, that it can help people with future planning. And from some studies, it suggested that the psychological harm is in fact actually quite limited, and simply people have the right to know. Arguments against it are that there's a lot of research as well showing that there's limited prognostic value in the biomarkers. It can lead to over-medicalization and to stigma and discrimination. It can induce psychological harm, such as problems with their mood and anxiety. And people also have a right not to know. And of course, there's the burden of the test itself. But so much for theory. Let's look at empirical work. What do patients think? And actually, only very few studies have looked at this in patients with memory impairment. And I'd like to highlight two qualitative studies on this topic. First, on the left, a study on decision-making, whether or not to pursue an amyloid PET scan in people with amnestic mild cognitive impairment. And this is based on 30 interviews. And people said they had the desire to understand the etiology of their symptoms. They had the desire to plan ahead, and also simply for knowledge's sake, even if the knowledge is not actionable. And again, people claim they have the right to know. And the authors of this paper conclude that there's a disproportionate focus on potential benefits, and people seem to overlook any potential harms. The other study on the right is a study that actually looked at the impact of communicating the results of an amyloid PET scan to people with amnestic mild cognitive impairment. And people who had a positive PET scan said, well, it allows me to make practical arrangements. But people with a negative PET scan, some of them were able to accept their memory complaints just as they are. But other people reported emotional difficulties after hearing the results of their PET scan. Some felt patronized by their partner and children. So this is the potential stigma and discrimination that we are sometimes afraid of. And also in some people with a negative PET scan, it did lead to confusion. If it's not Alzheimer's, then what is the cause of my symptoms? But we also need to know what doctors think. So we did in-depth interviews with Dutch GPs, geriatricians, and neurologists. And we asked them, would you aim for an early AD diagnosis using biomarkers? And what are your moral and ethical considerations for this? And this resulted in 6 clusters of considerations. First of all, the person-related considerations, with the most clear one, the doctor stating, well, it depends on the question of the person sitting in front of me. Then there are the test-related considerations. Doctors were critical towards the diagnostic accuracy, and also they added, if there's a slight increase of diagnostic accuracy, but uncertainty remains, then what's the added value for the individual patient? Then were care-related issues. Does it impact treatment? Now, I think as long as we don't have any disease-modifying treatment, care should mostly be should be symptom-based. So the actual underlying diagnosis should not be so much driving for the care. Then, of course, the setting. GPs have different considerations than people working in tertiary memory clinics. And some GPs argue that the careful follow-up visit could be just as valuable as a biomarker at a single time point. And then finally, there are disease-related issues that relate to society as well. Doctors bring forward by themselves the issue of the blurring boundary between health and disease. And they have a true fear of over-medicalization of aging. So I think this shows there's quite a large gap between the proposed research criteria and what doctors in clinical practice actually think and do. And these are all interrelated, these very complex considerations, of course. So it's time to take stock, and we can do that using the method of reflective equilibrium. We can assess to which extent the empirical findings are actually coherent with other argumentative elements. So the returning considered moral judgments are that people have the right to an early diagnosis, and that people could, or some argue even should, be offered biomarkers because it enables anticipation of health and it will lead to health benefits. First, we have to check whether this is justified by the basic principles of medical ethics: non-maleficence, beneficence, respect for autonomy, and justice. And I think I've shown that this is only partly the case. Well, second, we have to check whether this is actually supported by relevant facts. And I think the facts are that there's limited clinical and prognostic validity in biomarkers. And currently, there is no treatment available. So again, this is only partly met. And then third and final, we have to see whether these considered moral judgments are actually coherent.
Edo, can I, for one moment, can I please? There's some paper on your laptop, so that's why we cannot really hear you clearly, because we hear. Oh, that doesn't matter. Doesn't matter. Go ahead. You were concluding. Yes, go on.
Yes. So we have to see whether it's coherent with the background theories of health and healthcare. So this touches upon the concepts of health and disease, and also justice and healthcare priorities. And I think I've also shown that several questions remain open here. So I think the conclusion is that the context really determines on whether or not to pursue an early biomarker-supported diagnosis. And there's not a single answer to this question. So the shifting disease concepts really blur the boundary between health and disease. The reconceptualization of Alzheimer's disease actually takes out the mortgage on future research results, which may or may not come. And a timely diagnosis is not always an early diagnosis. And finally, ethical aspects of diagnostic disclosure are multifaceted, they're complex, and they're determined by the individual context of each individual person. So I'd like to thank the people from a multidisciplinary team with people from the Medical Ethics Department, from Erasmus Medical Center in Rotterdam, and from the Department of Public Health and Sociology at the University of Cambridge. Thank you very much for your attention.
Thank you so much, Edo. Thank you. Yes, well, you presented it. It's a complex matter. There's no easy answer to the questions that you raise, but we did propose the questions to our viewers. So when Jean is opening the poll right now, we would love to see your votes on this, because we know that it's hard, but maybe you can just pick the answer, the one you tend to, after considering everything, and the GP research, which was interesting also. We ask you, is a biomarker-supported early diagnosis of Alzheimer's disease in people with no dementia desirable in daily practice? Do we want that? The answer could be yes, people have a right to know, like you said. No, it's too uncertain what this means for the future of the patient. We cannot know, and you also described many other downsides to it as well. Only when truly effective and affordable medication becomes available, and like you said, not yet. So we would love to see what the viewers... Wow, look at that. That is not a big difference here. Only when effective and affordable medication, 34% for now. People have a right to know, 43. It's like that's like a ground rule. And no, it's too uncertain, says 23%, but they're still voting. Maybe we can switch to Jean, and thank you for now, Edo, because we will talk to you later about this. Jean, are you yes?
Yes, absolutely. It's
undecided.
An interesting result, right?
Yeah.
It absolutely shows that what Edo was presenting is a very hot
topic,
discussed topic at the moment in the dementia community.
Jean, what would your answer be? Yes.
Well, I have
it's a hard
to say,
one.
I'm torn in between two of the kind of answers, because I absolutely feel that patients, if a patient wants to get that information,
Yeah.
they should absolutely have that right to get information
If
about
they
their
want
health
to.
and their future risk of developing a disease in
Yes.
the future.
Would you
I
like to
also
know
think that it's
yourself?
more. It's really a question. It depends on at what stage of the disease I would be. If I have already some kind of early memory complaints, I would absolutely want to know
Yeah.
what the reason of that would be. But at this stage, I feel that my memory is okay. I would not necessarily want to know
You want to
whether
be,
some brain processes
course,
have
no.
already started in my brain
I
that
see.
may predict that I may develop Alzheimer's disease.
Yes.
in
No,
5 or 10
no,
years.
no standard test for people of, like, let's say 30. You don't
Absolutely.
want to do that. Okay. When
Not that I'm 30 years old, I would like to be that age. But,
yes, I see that. Oh, you are. Well, Simon Lovestone presented all kinds of problems, of course, but he said that in a year from 5 to 7, it will be better. And then we can do this again. We will see what happens there. So we will move on to our last speaker of the day, and afterwards we will and I'll make them answer the questions that you enter in the app just for a few minutes. But now we will proceed. We will go to Denmark, I know, in Copenhagen University. Gunhild WALDEMAR, she's a professor in neurology and chair of the Danish Dementia Research Center. She will be presenting the latest EAN guidelines on medical management issues. Hi, good morning. Good morning. Are you in Copenhagen or somewhere else? We still don't hear you, so I think you need to switch on. Yeah, hi, good morning.
Good morning. Yes, I'm in Copenhagen.
Copenhagen, yes, a wonderful city. So please take your 15 minutes and tell us all about the guidelines.
Yeah.
What makes
So it's a great honor for me to speak at this conference, and I would like to congratulate Alzheimer Europe, Jean George, with a very successful conference. I think it works very well.
Okay, Gunhild, WALDEMAR, sorry to interrupt you, but we cannot share. You did not share your screen yet, so you have to do that so people can take a look with you at your slides.
Okay.
Okay.
Is it correct now?
Is it correct now? Yes, it's working.
Okay.
Go ahead. Thank you.
So thank you very much for the invitation. And I will discuss actually what happens to people with dementia after the diagnosis of dementia and when they get other conditions, other medical conditions. Because people with dementia may not have sufficient access to appropriate health care. Or do they? Do we have a problem here? For people with at least moderate to severe dementia, it is a challenge to maintain a healthy lifestyle. They are vulnerable when they are affected with other conditions. And they are actually also at increased risk of getting infections, incontinence, adverse effects of certain medications, etc. Also, new medical conditions may go unnoticed in people with dementia because they do not have the initiative, perhaps, to talk about their symptoms. We know that lack of treatment or mismanagement or inappropriate medication may actually worsen symptoms of dementia and lead to maybe more pain, maybe more disability, hospitalization, or death. It is already well documented that people with dementia may not get the same attention for medical issues in our healthcare system as people without dementia. I think the COVID-19 is a very good example of that. And there is also to a certain extent, overuse of inappropriate medication in people with dementia. So in my opinion, there is really a problem, and there's something we can really do a lot about while waiting for the cure that I think all of us hope will come very soon or in a few years. Let me just show you a few data from our national Danish registries that illustrates the prognosis of people with dementia as compared to elderly people without dementia. As you can see on these graphs here, the mortality rates in people with dementia is about factor 3 above people without dementia, and that applies for women as well as men. There has been actually a decline in the mortality over the past 15 to 20 years, but the excess mortality in dementia remains. That is really in opposition to what has happened in cancer and in acute ischemic heart disease. The cancer curve here is the green one, the light green one, and the ischemic heart disease is the red one here at the bottom. As you can see, there has been a dramatic drop in mortality rate ratios over the past 15 to 20 years, due to, of course, much better treatments, as Simon Lovestone already alluded to, and also maybe better organization of healthcare. So the same dramatic drop in mortality has not happened with dementia, but maybe the clue behind increased mortality is not only the brain side disease in and by itself, but also increased mortality caused by inappropriate treatment and management of other conditions. Also, in many people's mind, dementia is not considered a fatal disease. And we often hear our governments prioritize investments in life-threatening diseases, meaning heart diseases and cancer. And we actually try to calculate, based again on the entire Danish population, just rough figures for the overall survival rate. Let us just look at here the 5-year survival rate. If you're diagnosed with cancer, is 42% in women aged 75 to 79. If you are a woman of that age and you're diagnosed with acute ischemic heart disease, the 5-year survival rate is 50%. And it's about the same level if you're diagnosed with dementia. So this leads me to argue that dementia is as fatal, or maybe as fatal as dementia and ischemic heart disease, and should be prioritized according to that by our governments. We have also documented that if you get an infection in dementia, if you have a dementia and then get an infection, your mortality is increased considerably, actually dramatically. So it is dangerous for people with dementia to also get infections. And the increased mortality is worse or biggest within the first month, but it actually can be identified up to 10 years after the infection in people with dementia. People with dementia also get much more medication than people without dementia, even if you subtract the necessary anti-dementia drugs. People with dementia, 62% of people with dementia, for instance, get 5 drugs or more, as opposed to 35% of people without dementia. And narrowing it down to potentially inappropriate medications, meaning inappropriate medications in elderly people, or at least medications you should use with great care. People with dementia who may even have more difficulty tolerating such medication get much more of it. In Denmark, as in other countries, we have seen a dramatic increase in the use of opioids, chronic use of opioids. And quite surprisingly, this increase is also occurring in people with a diagnosis of dementia. These people actually have much more difficulty tolerating opioids, and many of these are strong opioids and long-acting opioids. Maintaining a healthy lifestyle is important, as we all know. It may help prevent other conditions, and certainly increases quality of life and makes it more easy to live with a diagnosis of dementia. But people with dementia have much more difficulty maintaining a healthy lifestyle, or at least they need assistance in order to do so. And such assistance is not always available in our communities. So what can we do to improve this situation? This is very complex, of course, and there are many interventions that one could think of, and maybe the audience have some proposals also. Raising awareness certainly is important, that you should be aware, as if you have a diagnosis of dementia or you care for somebody who have dementia, how important it is to to keep a healthy lifestyle, but also how important it is to make sure or prevent other conditions such as infections. Also, there's a need to train primary care staff in observing physical symptoms and monitoring the effect and adverse effects of medication in people with dementia. In many countries, I think we will hear more about this in the afternoon. There are projects developing dementia-friendly hospitals, and here training of hospital staff in identifying physical conditions and inappropriate medication is also important. What we wanted to do was to develop a guideline for physicians in Europe in medical management issues. And I will just briefly explain how we did this. And the lead person in this initiative was Christian Steen Frederiksen from my group, and it was done together with a multidisciplinary group of European experts. There are numerous topics one could choose to cover, but we were limited to 5 conditions or topics, and they were selected based on the fact that we knew there were significant variations in treatment across centers, regions, and countries, unmet needs in relation to management issue, additional costs associated with mismanagement, or where mismanagement may be associated with considerable negative health consequences. So we ended up selecting these 5 medical management issues. Is there a need for systematic medical follow-up in dementia was the first. How can we manage vascular risk factors in dementia, and is that important? And how to treat pain in people with dementia. Appropriate treatment with antipsychotics in dementia, and management of epilepsy in dementia. I will not have time to go through all the details in this guideline right now, but very briefly, we based our recommendations on a very thorough study of the literature and all the evidence that we could find, and developed either evidence-based recommendations or good practice point where there were little evidence. And such a good practice point is that persons with dementia should be offered regular pre-planned medical follow-up. For vascular risk factors, we have a weak recommendation for treatment with anticoagulants in persons with dementia and atrial fibrillation, and also that systematic management of vascular risk factors should be done in persons with mild to moderate dementia because it may impact on the progression of dementia. For treatment of pain, our recommendation is that discontinuation of opioids should be considered in persons with dementia for whom there are no complaints of pain and no clear indication, and where mild analgesics have not been tried, and in persons in whom there is suspicion of side effects such as rapid cognitive decline, sedation, falls, respiratory problems, constipation, nausea, or reduced appetite. We also had a weak recommendation against treatment of behavioral symptoms in persons with dementia with mild analgesics, which has been proposed by some groups. In terms of treatment with antipsychotics, we have a weak recommendation against the general treatment of persons with dementia and agitation, aggressive behavior with modern or atypical antipsychotics compared to no pharmacological treatment. And of course, this recommendation stems from the fact that, that other interventions should be tried as a first initiative. In terms of, for the epilepsy topic, a good practice point, because there was very little evidence, is that newer anticonvulsants should be considered as first-line treatment of epilepsy in patients with dementia due to their lower potential for drug interactions, lower incidence of adverse effects, and linear pharmacokinetics.
Yes, and Professor Waldemar, we want to provide these options, these 5 areas from the guidelines to our viewers, so they can vote.
A final thanks to the group. There's a photo on the list of names here, and I recommend that you also attend the session tomorrow from 1 to 2 p.m. for a more detailed presentation.
Yes, that would be lovely. So thank you so much for that conclusion. For now, please stay with us because now we will bring in our international team of speakers all together so you can share a screen together and we will talk to all of you. And Jean will be here as well, and he will be opening the poll to see what your answers are to this. Look at that, that's a nice crowd from all over from all over Europe and further. Oh, I did get a message through the app that also in Israel it's sunny. Well, we're very happy for you. Very happy to know. So maybe we can take a look at the results. What did people think after you explained so well, Professor Waldemar? All right, let's see. Systematic follow-up. First option, highest votes. Pain, you were talking about that. 18% antipsychotics, 27% vascular risks, 13%. Systematic follow-up, highest score. What do you think, Gunhild Waldemar?
Well, I'm very pleased to see this result. I think it is absolutely crucial that people with dementia are offered systematic follow-up, either from the GP or from a specialist clinic. And the setting, of course, will depend very much on the problem or the disease or the what's possible.
Yes.
Because people with other chronic diseases are offered follow-up. People with epilepsy, people with Parkinson's disease, but very few people with dementia have access to a physician who can advise them on a running basis.
And that's quite important. They feel the same. Well, if we go back to all of you, yes, Jean, there were many questions coming in, and because we always have limited time, we're going to try and answer as many questions as you can. So short questions, short answers, and just a fire of questions, and we will get there. Jean, will you ask the first question?
Well, I see that there's a number of questions from the audience, and one of them is really around, well, what could we propose as prevention programs? So
exactly.
That's something that
Pierre
could address, yes.
They want to know, what does the dementia program, prevention program look like?
Yes, we have to consider prevention at the primary stage of prevention, but also secondary prevention and tertiary prevention after the diagnosis. And what the evidence shows that at the center of the program, the prevention program, is the physical activity, the nutrition, and the social life. So with these three main direction, we have a very good evidence that at the primary prevention stage and also secondary, we are efficient to delay the cognitive and functional stages of the diseases.
That's kind of hopeful if you can influence the risks with these aspects, right? Like nutrition and lifestyle.
Yes. The evidence is clear in the literature, and we have to apply this all during life, obviously, but it's also efficient at late life stages of life. So when the disease has begun, we can still adopt this kind of way of life by promoting physical activity, a good Mediterranean style of nutrition, and a good rich social life that enrich the cognition, that stimulates the cognition.
Thank you so much. Edo, many compliments for your presentation, which is lovely. Somebody asked, well, if people want to know their dementia risk, they have to know what that diagnosis means. Do they know that when they ask for it? What do you think?
I think it's an excellent question. It's really core to what also the doctors said in the interviews. The first concern is, what is the question of the patient sitting in front of you?
Yes.
And it's also shown from the interview studies with patients with the consideration to whether or not to pursue a PET scan, an amyloid PET scan. Do they really realize that there are also downsides, and people should be very well informed about what potential benefits there are and which potential harms there are.
Yeah.
And we've also learned from people in a lot of research that I did with Richard Milner from Cambridge, that if you really explain to people that after doing a biomarker test, things are still uncertain, although a little bit more certain,
Yeah, just a
then a
little.
lot of people say, well, then I'm not so interested. If you tell them after this test you will know, then the majority of people says, okay, I want to know.
Yeah.
But if they understand that there is still uncertainty, then the number
Why
of
should
people
you?
that wants to know really drops dramatically.
Yeah, I can understand that. So, Jean, what's your next question you want to ask too?
Also, there's a question for Simon, and a question around basic versus clinical research. And somebody feels that maybe if you had invested more in basic research, we would be closer to finding better targets for the treatment of Alzheimer's disease. Would you share that belief, or how do you see the difference between basic and clinical research as priorities?
Well, first thing to say is I think there should have been more research, full stop. So there should have been more funding for research 20 years ago, 30 years ago, and even today. We need more funding. I won't remember the statistic exactly, but I think it was Alzheimer's Research UK showed something like for everybody with cancer, there was about 250 euros put into research, but for everybody with dementia, it was only 10 euros. So we just need more research. I think that we can't do without basic science, but I wouldn't want to choose between them. You need both basic science and clinical research. Over the years, the need for clinical research becomes increasingly paramount, and I think we're in that period now.
Okay, thank you so much. Professor Waldemar, somebody states in the app that she or he feels that pain in particular is not appropriately investigated. What do you think? Is that a neglected area?
Absolutely. I think that is absolutely right, and there's so much more to do. First of all, we are uncertain about how can we assess pain in people with dementia, particularly in people with severe dementia.
Yes.
And as I talked about just before, we also have the potential problem of overtreating pain in people with dementia.
Overtreating, yes? Is that the case?
Well, at least I think the very large fraction of people treated with a long-acting, strong opioids seems not to be justified by any pain-giving conditions.
Okay, I see. So we misunderstand other symptoms for pain.
Maybe, yeah.
Maybe, yes, I see. Jean, what's the question you want to ask before we wrap this up?
I think you've covered almost all the questions from the audience, but I think there was a questions around the diagnostic criteria for research settings and clinical settings, and maybe that's a question for both Simon and Edo. And do we really need separate diagnostic criteria for research and for the clinic, or should we use the same?
It's a question,
Simon and Edo.
Edo, first.
Edo, should I have a start and then you? So
yes,
we're going through a difficult period when we have increasingly effective and accurate biomarkers, albeit with some uncertainty about outcomes of those biomarker tests. But these are perfect for research. But as Edo has explained so carefully, it's difficult to see their implementation before we actually have the results of those research. So let me give you one of the most, I think, tragic statistics, and that is that in the clinical trials for amyloid, up to 20, and in some studies more than 20% of people that were in those clinical trials actually didn't even have amyloid in their brains. There is no way a drug will work if you don't have the pathology that drug is designed to prevent.
Of course, yes.
Today, we have the biomarkers that allows us to say, you have amyloid, you have tau, this is how much you have, and this is going to be the right drug to test in you. And for research, that is what we've been lacking, and now we have.
Thank you so much. And Edo?
Yeah, it's a very careful answer, and I fully agree.
Careful?
Yeah, I think so. And the thing is, if we completely separate research criteria and clinical criteria, we risk that researchers start investigating things that at the end of the road are not in line with what patients and caregivers think is important. So it's okay to have specific biomarkers and really apply them to do specific research for specific drugs. I think this is very good. But I do think we should be very careful completely separating research criteria from clinical criteria, because we end up in a lot of semantic confusion, and research may take a different turn off than patients would like.
I see. So thank you so much, Jean. Let's wrap this up, our panel here, because we will be saying goodbye to you, and thank you so much for your contribution. This was really an interesting discussion. And later on we will be back, but first of all, you say goodbye, Jean. You're the chief here.
Absolutely. I thought this was a really fascinating discussion, and thanks to our really world-class speakers on updating us on the latest trends when it comes to diagnosis, treatment, and medical management of Alzheimer's disease. I think there's a lot of food for thought for us to take in for the rest of the day. So great starts in my opinion.
Thank you so much, from Lyon to Copenhagen, and then we will talk to you another time again. Goodbye. Thanks a lot. Thanks a lot. See you. So, Jean, we'll be moving on to our sub-sessions, workshops, all the different breakout sessions, and they will start at 10:45, the first round. And then there will be a break at 12, but there will be quick presentations there and poster presentations, so there'll be activity all day long. And after that, at 13:35, again, another round of breakout sessions. And we will be back for another segment, and we will be talking about dementia-friendly societies this afternoon. So we will start that at 15:45, but there will be a little music again before that. So please join us at around 15:35, and please keep entering your questions. And we really love your tweets around the content of the conference, but also the cats and dogs tweets, right? Still, the rain is
keep
still...
those cats and dogs coming. Absolutely.
Yes, and the rain is keeping the cats and dogs coming as well. It's really, really raining heavily here. So, okay, what else do you have to say?
For me, absolutely. Just one thing as well, like we have two special symposia that were supposed to be happening at lunchtime. One of the European Working Group of People with Dementia, one from Roche around the impact of the COVID-19 pandemic. And both of them have been pre-recorded, so you can watch them at any time that you want.
Good.
So, but please make sure these are two very, very interesting symposia. Okay. Check them out.
Check them out.
At your leisure.
You can see them on demand. So, and of course, there are sponsors here and people who have made everything possible for this conference. So when we leave, let's take a look at their names and the companies that helped us do this, right? I'll see you this afternoon, Jean. Good luck with all the sessions. Bye-bye. And see you later, and have a good day.